Hello and welcome to the Parkinson's Foundation's Wellness Wednesday, Parkinson's 101. I'm Krista Ellis, a Community Engagement Manager for the Parkinson's Foundation. Helping me behind the scenes are my colleagues Jenny Fierde and Elizabeth Guerrero. We warmly welcome you to the webinar today, especially anyone joining us for the first time. As we begin, we want to welcome you and take a moment to share the mission of the Parkinson's Foundation. Every day and in everything we do, we are working to make the life better for people with Parkinson's. I wanted to share with you how very apparent your Parkinson's community is joining us today in real time, representing 7 countries around the world, from Argentina, South Africa, the United States, the United Kingdom, Germany, Australia, New Zealand, and everywhere in between. We welcome each of you who have decided to show up for yourselves and for your loved one affected by Parkinson's disease. 50% of our participants today are people living with Parkinson's. 23% of our participants are care partners, and 17% of each of you are adult children with a parent who has Parkinson's disease. Your community is here with you across the globe and present at this time. To achieve our mission, we pursue 3 goals: improve care for everyone with Parkinson's, advance research toward a cure, and empower and educate our global community. Today's program is a great example of one of the things we're doing to help us meet these goals. If you'd like, please share with us in the chat where you are joining us from today. One example of our mission in action is PD generation. This research offers genetic testing for PD-related genes and genetic counseling to people with Parkinson's at no cost. Commit to helping us advance Parkinson's research today. You can check your eligibility and enroll now to be part of PD generation at parkinson.org/PD generation. If you are looking to get involved, we're excited to share our initiative meant to capture the community's perspective on various topics in Parkinson's disease. We hope that you'll join us by signing up for this initiative, where we invite you to complete a 10 to 20-minute survey on various topics such as mental health, telehealth, and care partners. We always report findings back to the community. You can learn more at parkinson.org/PF surveys. I am now pleased to introduce our speaker for today, Dr. Ergun Uç. Dr. Ergun Uç, Professor of Neurology, is the Director of the Division of Movement Disorders and Parkinson's Foundation Center of Excellence at the Department of Neurology, University of Iowa Hospitals and Clinics. Clinically, he is involved in all aspects of the care of Parkinson's disease patients, including deep brain stimulation, both at UIHC and Iowa City VA Medical Center. Dr. Uç was the chair of the Cognition Behavior Work Group of the Parkinson's Study Group and was a member of the Scientific Review Committee of the PSG. He has served as the associate editor of the journal Parkinsonism and Related Disorders. His research focuses on cognitive and motor aspects of Parkinson's disease, including driving and behavioral interventions such as exercise. He has received research support from the National Institutes of Health, Department of Veterans Affairs, Department of Defense, as well as Michael J. Fox Foundation, American Parkinson's Disease Association, and Parkinson's Disease Foundation. Please join me in welcoming our expert speaker, Dr. Ergun Uç.
Well, thank you, Krista. I thank Parkinson's Foundation for inviting me. I also see that my picture on my bike was shared among the choices I gave. So this picture was taken while I was participating in RAGBRAI. This is an annual bike ride across Iowa, about 500 miles over 7 days. And I was in the at the University of Iowa Children's Hospital team. So this is the jersey from the Children's Hospital team. And when I was entering a town, together with tens of thousands of people, I saw a telephoto lens right by the side of the road. So these are rural roads in Midwest. And just happened to look at it. And then a few days later, I was sent the link to this picture and to an article. I think that's probably the best photo of my life, and it was taken without my knowledge. So in any case, I also am very much into exercising personally, and I also do research on aerobic exercise in Parkinson's disease, which I will share later. And with that, I will start sharing my screen now. Sorry for that here. So our topic is Parkinson's 101. And I might perhaps go sometimes into too much detail, but hopefully I can try some answer questions here. So I'm, as mentioned, from the University of Iowa and the VA in Iowa City. I have various grant support, but no conflict of interest with what I'm going to talk about. So today we will talk about what Parkinson's disease is and the causes, the symptoms, disease management, and research. So Parkinson's disease is a neurodegenerative, progressive brain disorder. We don't know the exact cause, and there is no cure, so meaning that we cannot really stop and eradicate the disease, but we can treat the symptoms effectively in most patients so that patients live a productive life with good quality for a significant number of years after diagnosis. It can affect different components of our lives, movement, mood, and thinking. Initially, it was thought to be only a movement disorder because of the shakes and difficulty walking and slowness. But over the years, we have realized that it affects many other functions: psychology, mental function, sleep, different inner organs in many ways. And we have reasonably effective medical and surgical treatments, but also healthy lifestyle choices really can make a difference. So it's a relatively common disease. In the US population, about 0.3% across the population have Parkinson's, and this number increases when you go above age 60. And a proportion of patients are younger, like even in their 20s, 30s. But most patients are 60 years and older. And what are the causes? Again, the cause is unknown, but it's probably a combination. So there is a saying, genetics loads the gun and the environments pull the trigger. Environmental factors pull the trigger. So basically, probably it's a combination, meaning that some people have a predisposition to develop Parkinson's disease, and if they meet the environmental exposures, then they are more likely to develop it. But about 10 to 15% of all patients can be due to a single gene mutation, so purely genetic. And there is still ongoing research. And there are 7 or 8, and the number is increasing each year, unique genes, and genes are the DNA blocks that code for a protein. There are 7 or 8 unique genes that can cause Parkinson's. So that means that Parkinson's disease is probably not one disease. If 10 to 15% of all Parkinson's is caused by 7, 8 different genes, so imagine that across the whole population of people with Parkinson's disease, there could be many other processes. So meaning, although many patients have similar manifestations, the road that takes them there is different in everybody. And we are working to understand each of these different pathways that lead to Parkinson's disease. And the cure will be really to identify each different pathway and try to intervene in that pathway. So similar to cancer, you can treat some cancers, but not others. And the ones we treat, we know what causes them and we know the pathways. So I think Parkinson's will follow a similar path. So of course, again, older age and traumatic brain injury are risk factors for Parkinson's. Now I will show you the motor symptoms. So the motor symptoms of Parkinson's disease, or the movement symptoms, consist of several components. The most important, the one has to have in order to be diagnosed with Parkinson's, is bradykinesia, or slowness of movement. Many patients, but not all, have rest tremor. So rest tremor means shaking while you are not doing anything, just resting your especially the hands, maybe on your lap and do nothing, and it shakes. And also rigidity, stiffness in the muscles, and gait and balance problems. If you have bradykinesia and one of these three, then you have the motor symptoms of Parkinson's. We also call that complex Parkinsonism. So here, let's see a patient here. So this patient is being evaluated for deep brain stimulation. He is 7-8 years into his illness, and he shows what we call motor fluctuations. So he held his medications overnight, and that's how he looks in the morning before he takes the medication. So as you can see, he has the resting tremor, both in the upper extremities and legs. And the tremor improved a bit when he held the posture, because most rest tremor goes away when you go away from the resting position. We are also seeing that he is slow and slower on the left. And as you see, tremor is also more on the left. So typically Parkinson's is asymmetric. So again, we are seeing the slowness, and the maneuvers I'm asking him to do are part of what we call the Unified Parkinson's Disease Rating Scale. And then we rate how slow or how stiff patients are so that we can keep track of their symptom severity. So we also see that his facial expression is diminished. And his legs are also slow, similar to his hands and arms. Again, the right side is a little better than the left. So now, the second video is about an hour or so after he took his carbidopa levodopa. So now the tremor has gone away. And his facial expression is a little more lively, and he's faster. So this is a very crisp effect by dopaminergic medications. Very crisp effect. And when we have this type of good response, we are more certain about the diagnosis of Parkinson's. Although Parkinson's is not fun to have, there are worse diseases, which we call Parkinson plus diseases, like PSP, progressive supranuclear palsy, multiple system atrophy, corticobasal degeneration. So in those diseases, patients don't respond to medication, either very little or not at all. So the fact that he is responding real well after several years clinches that this is more regular Parkinson's disease and nothing else. We are also seeing some abnormal head movements. We call these peak dose dyskinesia. So after some time, even though the medication helps, patients overshoot a little bit. So from being real slow with little movement, their movements may increase, and you might have observed it on some clips of Michael J. Fox. By the way, younger patients. So younger patients have more dyskinesia than older patients. So we have seen here all the different Parkinson manifestations, motor symptoms, and also how well they can respond to dopaminergic medication. So my apologies that this slide is a little bit perhaps too complicated, but what it shows is this is the brain, and then these are parts of brainstem, midbrain and lower parts of the brainstem. So this area is what we call substantia nigra, and this is substantia nigra means black substance. This is in a person from an autopsy from a person without Parkinson's disease, sorry. And this is from an autopsy from a person with Parkinson's disease. So substantia nigra is black because the dopamine cells have a black pigment in them called melanin. And because patients with Parkinson's lose dopamine cells in substantia nigra, they also lose the black color. So it becomes pale. And in Parkinson patients, that area called substantia nigra has also, you might have heard, Lewy bodies, which is the typical pathologic manifestation of Parkinson's. So in this substantia nigra, brain cells, dopamine cells go all the way to the middle of the brain or to the base of the brain called the basal ganglia. And that is very important for control of movement, calibration of movement. So when you lose that pathway, when dopamine is reduced in that pathway, then patients cannot calibrate their movements very well. They can't scale their movements. They cannot initiate their movements. That's why we see all these slowness, stiffness, discoordination, and tremors. So dopamine is but not only limited to substantia nigra and movement. There are other parts in the brain that also use dopamine as their messenger. And they are important for emotion, behavior, and cognition, meaning like mental function, attention, decision-making, executive functions. So when there is dopamine deficiency, in addition to movement disorder, people also may have depression, decreased pleasure from life, and also various cognitive manifestations. Now, this is the basis of the motor symptoms of Parkinson's. So this connection connection here is again depicted here. See when it's healthy and when it's not healthy. Now, however, we see several other different colored lines here. So the chemical deficiency in the brain in Parkinson's is not limited to dopamine. There are other chemicals that are also deficient called norepinephrine, serotonin, acetylcholine, and these different colors show the pathways that have deficient brain chemicals in Parkinson's disease. So all these different. So what does that cause? This is what it causes. Because of these changes, people have difficulty with their inner organs. So your heart itself or your bowels or your bladder itself might be normal, but the nerves and the brain centers that control these nerves that go to these organs are impaired because these chemicals don't work as messengers anymore. As a result, people get autonomic dysfunction, orthostatic hypotension, such as drop in blood pressure upon standing up, constipation that can even start long before Parkinson's disease is manifest, the tremors and stuff. Urinary urgency, sexual dysfunction can also be present before the disease is diagnosed. And a good number of patients also have what we call REM behavior disorder. So during our sleep, when we dream, our body goes limp. So in Parkinson's, there is a condition called REM behavior disorder, rapid eye movement behavior disorder, when the body doesn't go limp during dreams. So people act out their dreams. They can even fall off the bed. So this is this major sleep disorder. There's also insomnia and excessive daytime sleepiness. Loss of norepinephrine, serotonin can cause depression, anxiety, and eventually decrease in all of these, especially acetylcholine, can lead to hallucinations and psychosis. And visual acuity is diminished, especially the patients with Parkinson's have difficulty at night seeing shades of gray. And again, as I mentioned, attention, executive functions, memory, visual spatial ability, so meaning recognizing things in space and judging their relationship to each other is impaired in Parkinson's. And even at the time of diagnosis, 20% of patients with Parkinson's may have what we call mild cognitive impairment. Across all people, 30 to 40% have dementia, meaning further cognitive impairment. And if people live long enough, get old enough, like if they have Parkinson's disease for 15, 20 years or longer, and if they are close to 80 or higher in terms of age, a very large proportion of Parkinson patients develop dementia. It's a cause of dementia as well. So now there are many signs. I already have mentioned them. Let's recap. Like tremor, we know, difficulty walking, small handwriting, constipation, dizziness, stooping, soft voice, masked face, trouble sleeping, loss of smell. So some of them are motor functions, some of them are non-motor functions. Like the things I mentioned here are non-motor functions. They are not, you cannot exactly see them. And that's like an analogy of an iceberg. So on the surface, you see patients shaking, maybe a little slow, but that's really the tip of the iceberg. The bulk of the bulk of the problem is below the water level. So people may have depression, anxiety, constipation, sleep disorders, and if your provider is not very familiar with Parkinson's, they might just concentrate on about the water level. Whereas under the water, there is much bigger proportion of the iceberg, where Titanic hit basically. So therefore, it's very important for patients to realize that Parkinson's may have many manifestations in addition to tremors and slowness, and also for providers to know and probe for these different non-motor manifestations. So it's really, once a patient is diagnosed, it's a lifelong illness. And the more you and your loved ones know about the illness, you will be better advocates for yourself and be better participants in your care. So I mentioned here various cognitive, motor, visual manifestations. So all these lead to difficulties in life. I have done and still do quite a bit of research on driving. And in our research in patients who are relatively mild, who drive themselves to appointments, we compare them to people without Parkinson's disease around the same age in and around Iowa City. And we found that patients with Parkinson's disease did a lot more at-fault errors when we counted their errors over a 20-mile, 40-minute drive. And the main, and also if they did multitasking, meaning like talking on the phone or doing other things, not paying attention to the road, their driving got much worse compared to people without Parkinson's. And the main predictors of poor driving were not tremors. It was the cognitive and visual dysfunction. And so 2 years later, 70% of the controls and 40% of the Parkinson returned. And what we saw was that the people who returned were similar at baseline, the cream of the crop of Parkinson patients returned. So why did the others not return? Because they already had quit driving by the time we had invited them back. See, this is the proportion of people driving with Parkinson's and proportion of people driving who are controls. So The people who seem to have problems appear to have quit. But in the cream of the crop, 2 years later, what we observed is their error counts got much worse over 2 years compared to the control. So in Parkinson's, just one-time evaluation is not enough. So probably annual evaluation is a reasonable frequency to evaluate driving. So to be safer while you drive, avoid driving at night, be aware of limitations, of course, in inclement weather, in unfamiliar locations, avoid busy intersections and unprotected left turns, avoid distractions such as phone, conversation with passengers, even listening to radio can disturb your concentration or eating. So always keep your eyes on the road. Now, I will recap the symptoms here. So the Parkinson's, the hallmark of the Parkinson's are the motor manifestations, tremors and so forth. And considering that PD has a duration of 15, 20 years or longer, depending on the age of person and the subtype of their disease, here you see -10, so meaning before the motor symptoms become manifest. So over these 20 years, medication effect diminishes, then they don't work. Walking and balance become real problematics. There are difficulties with swallowing, falling, immobility. So the motor symptoms become much more recalcitrant over the years. So initially, we treat them with medications. Some patients are candidate for DBS, but later our main weapons are PT, OT, speech, and palliative care. But we should also engage them even earlier to increase the quality of life. Now, there is also this premotor or prodromal period. Premotor means before the motor symptoms. Patients may become constipated up to 20 years before their illness is diagnosed. They may lose smell years before the disease is manifest. They may have others like stomach emptying, bladder urgency issues. So these are the autonomic signs. And with progression, the more prominent orthostasis, dropping of blood pressure and even passing out from that can become a real problem. Sleep, the acting out dreams, can be present before the disease is diagnosed and can be a predictor of what's coming. Many patients have also insomnia and daytime sleepiness. Depression, anxiety can occur before people are diagnosed, but it's of course hard to know at this stage if this is from Parkinson's or from something else, because these are very non-specific. So therefore, many times our clinical trials start around here, but this is a little bit too late really to intervene, because by the time people have manifested, they lost about 60% of their dopamine function. So depression, these are the psychiatric symptoms. So can start with depression, anxiety. Apathy means losing interest without being terribly depressed, hallucinations, psychosis, and cognition, initially mild cognitive impairment, and people can go on to dementia. So all these, it's a little bit luck of a draw. As I said, there are 7-8 unique genes explaining 10-15% of Parkinson's. Because people come at Parkinson's from different directions, their trajectory, once they arrive there, is also different. Some people progress faster, some people progress slower. Some people have less of these non-motor signs, some people have more of these non-motor signs. It's a little bit luck of a draw, I must admit. So as a result of these different problems, job, social life, driving problems, they affect people, in the early years when they are still functional. So when they are really advanced, they cannot participate in these. But in the first 5-10 years or even longer, depending on the age and general health and the subtype of Parkinson's, people can still be able to continue their life close to normal with good management. So this is another picture which shows that, from the beginning to the end, that if people start earlier, if people start earlier, younger, they live longer with the disease, but they may have more motor fluctuations. And if people are older at the time they develop the disease, they may not show much of the fluctuations. These are the signs, what we call the poor prognostic indicators, like nursing home placement, dementia, treatment-resistant falls, hallucinations, psychosis. Unfortunately, there is an interaction of Parkinson's with age. So the more wear and tear in the body and brain, the more Parkinson's disease hurts the patients. So therefore, there is a statistical increased probability that people may have these poor prognostic indicators in their mid-70s. But again, everybody is different. I have 90-plus-year-old patients who just function fine, and 60-plus-year-old patients who are in really advanced stage. So how do we diagnose Parkinson's? So diagnosis of Parkinson's is really mainly based on good history taking and examination. There are no great tests. So sometimes we also use response to Parkinson medication as both a diagnostic test and also a treatment maneuver. There is a test called DAT scan, dopamine transporter scan, you might have heard. It's not completely foolproof, but can help us to differentiate if your tremor is from something called essential tremor or from Parkinson's disease in particular. There is lots of research going on. I'm also part of a three-institution research group funded by Department of Defense. We are working on developing a blood test for Parkinson's disease to see if the abnormal protein in the brain, the alpha-synuclein, can also be measured reliably in the blood. And it would be wonderful if we can confirm that it works, because then we can diagnose Parkinson's with a blood test and perhaps start treating them very early if we can show that they're on their way to Parkinson's based on a blood test, for example. So this research is still ongoing, and I'm doing it mainly at the VA here. Now, how do we manage Parkinson's? So when I was a resident and fellow in 1990s, it was more paternalistic. The doctor decided basically more or less everything, and the patients abided more or less. But now it's really a collaboration. So all four legs of the table. So on the conventional pharmacotherapy, so meaning the drugs, device-aided therapies, meaning like deep brain stimulation, multidisciplinary care, like with other colleagues from physical therapy, occupational therapy, speech therapy, psychiatry, neuropsychology, but also you are really a very important part of this table, informed and engaged patients and caregivers. And here, I think Parkinson's Foundation and similar organizations do a great job in engaging patients with Parkinson's disease, bringing Parkinson specialists, care providers with patients and their caregivers to increase awareness and understanding of the disease. So it's very important aspect. So at the university, we were designated a center of excellence by Parkinson's Foundation in 2018. We really benefited a lot from their network and know-how in organizing patient events and getting together with patients. And we started doing patient symposia. So far, we have done on Zoom, and these can be found on the YouTube channel of the University of Iowa Healthcare. So when to start treatment? Again, treatment as of now, is symptomatic. So meaning it treats the symptoms, but it doesn't stop the progression of the degeneration. So therefore, it's in the eye of the beholder. So some patients may prefer to go without drug treatment, and others may be very sensitive even to a little tremor. So this is something you need to discuss with the neurologist, with your care provider. And again, there is no, so Parkinson medications really don't slow down, but they can certainly improve your balance, especially early on, can make your walking more steady. So therefore, if you start taking Parkinson medication when needed, it would really help you to improve your quality of life. And there is really no benefit from delaying the taking medications. So research has shown that people who started early in the disease or late in the disease were at the same spot like 10 years later. So therefore, don't be stingy on getting treated because you just lose years with quality of life if you don't get proper treatment. So this is, I guess, obvious that finding a qualified provider is very important. And as I mentioned, work, and I will come back to the theme again. So the medications and surgical options we'll discuss, and also the importance of other allied specialties, such as PT, OT, speech therapy, and also the role of exercise. So medications mainly boost the dopamine system in different ways. So, and I will not go into detail, but what the end result is having more dopamine in that particular part of the brain between substantia nigra and the base of the brain. So levodopa was discovered in like 1960s, 1968. And although it's the oldest, it's probably the most reliable because it's a natural amino acid and it becomes dopamine in the brain. But because we are giving it by mouth, so it more comes in spurts, produces dopamine in spurts rather than very gentle elevations, very gentle leveling in the nature. Dopamine agonists are synthetic agents that act like dopamine, like ropinirole, pramipexole, rotigotine. They have various advantages like longer effect, but also disadvantages in terms of side effects, impulse control disorder, orthostatic hypotension. MAO-B inhibitors is an enzyme that blocks breakdown of dopamine in the brain, and COMT inhibitors like carbidopa and COMT inhibitors, they boost the effect of levodopa by making it more available to the brain. So this is the effect of levodopa over course of Parkinson's disease. So the first 5 years are called honeymoon period because patients may take, let's say, 1 tablet carbidopa, levodopa 3 times a day, and they would be in the on state throughout without much change. So this is off is like the patient I showed you, he was shaking quite a bit, that's off state. On is when they are quite ideal. The green and blue is dyskinesia. So our patient we saw was doing this, he was fluctuating but he didn't have severe dyskinesia. So this is another way of depicting it. The on periods decrease over time in Parkinson's disease, the off periods and dyskinesia increase over time, and the medication need increases over time in Parkinson's. So what about surgical or more invasive treatments? So there is so duopa, some patients use it. It's basically levodopa being delivered into duodenum through a small feeding tube. So it provides more stable dopamine supplementation, but it's certainly not very pleasant to have a feeding tube when you really don't need it for nutrition. And so there are now pumps that are intradermal, easier to use, are coming to the market soon. So deep brain stimulation has been around for more than 20 years. It was first developed by the company that also developed the cardiac pacemaker. It works like a brain pacemaker, basically. So this is the battery or the pacemaker device, essentially. It gets connected to these wires that go deep into the brain and change the signals and the oscillations in the brain. So all brain function is really actually a propagation of electrical signals and networks in different patterns. So, but deep brain stimulation is not for everybody. So you have to have regular Parkinson's, not atypical Parkinson's or Parkinson plus. And you have to have disabling ups and downs, but still a short but good response of dopaminergic treatment. If you don't have any response to dopaminergic treatment, if there is no change in your symptoms at all, even for an hour in the day, then DBS will not help. It can make it even worse. No dementia or major psychiatric disease, no disabling medical or orthopedic condition, no disabling gait disorder while on. So meaning if your balance and gait is very poor, even when the medication is working, DBS will not help you. It can make it worse. And it's a complex treatment. They put a system into you and it requires care and TLC and frequent visits to the doctor. So you have to have a supportive social environment. Not for everybody. So on average, probably 10-15 of all Parkinson patients get DBS. So this is a patient, relatively young patient who got DBS. So this is before surgery. So we see that he shakes real bad when he's off medications. And now and now I gave him his medications, and he has like violent dyskinesias, like much more than the other gentleman. So then he had the deep brain stimulation surgery, and that's before I activated his DBS, and he's not on medication. So the same situation like here, the DBS is not on yet. So he's still shaking real bad when there is no medication or no DBS. And the same morning, before I gave him the medication, but just turned on the DBS, so you can see that patient has improved quite a bit. So, so this is like an ideal case where you have significant motor fluctuations and dyskinesia. The patient is young and relatively young and without any significant medical or psychiatric condition. So, and really in such a patient, usually there's good response. And this is his profile. He would be either very severe dyskinetic or very severe off, very little good time. But he had good time. So therefore, he was a candidate for surgery. So once you have DBS, it's like rewinding the clock in terms of motor symptoms, like your on periods get longer, off periods and dyskinesia get shorter. There could be some decrease in your medication use, but that's not the goal. We always use them together. So don't expect to go off medications when you have DBS. But unfortunately, it doesn't stop neurodegeneration. So if people are going to get demented, they get demented. So physical therapy, we spoke about the team, physical therapy, occupational therapy, speech language, very important. Again, they are more critical when the disease has progressed quite a bit and medications and DBS don't work anymore as much. But even early on, it would be good to introduce our patients to these different disciplines so that they can improve their quality of life while they are still reasonably functional. So it doesn't need to be like an advanced stage intervention. Mental health is very important. Again, depression, anxiety, apathy are part of Parkinson's in many patients, and there are different ways to evaluate and treat. So there are different challenges, and the therapists and various allied team specialists can help us to overcome the predictability, give us a sense of control, more independence, improve our lifestyles. So how can we improve our lifestyle? Moving more, perhaps eating more Mediterranean style diet. Frankly, alcohol is a neurotoxin, and perhaps early on in moderation, it might not hurt, but in general, it would make the motor and cognitive symptoms of Parkinson's disease worse, because, it results in less balance and slower thinking. So lifestyle change is important. And again, very important, reflect on your identity. So don't let Parkinson's disease define you. I know many people who are living with Parkinson's disease, who lived with Parkinson's disease and functioned well in high-stake jobs. So as long as the disease doesn't cause significant cognitive dysfunction, many people can continue their life in a rather satisfactory way. Now, palliative care. So palliative care, Parkinson's Foundation is doing a great job also in promoting palliative care. And we are part of the palliative care network of Parkinson's Foundation at the University of Iowa. So palliative care gets confused with hospice, giving up on the patients, and as if it's only for imminently dying. Or if somebody refers you to palliative care, is it like a death sentence? None of that is true. So palliative care, so as neurologists, we kind of more concentrate on the symptoms, give you a little bit of medicine, give you DBS, improve that symptom, decrease that tremor, but perhaps we are not looking at the patient as a whole, as we should be. But when you work with a palliative care provider, they have a more global look at the patient. They more look from the angle of quality of life, not treating this or that symptom. So they concentrate on reducing the suffering. Of course, we all try to do that as physicians and healthcare providers, but palliative care specialty is to have this more global, wholesome look at the patient. So therefore, palliative care really should be practiced at any stage of Parkinson's. Maybe talk to a palliative care specialist at the time of diagnosis, and then you will be going and functioning good for a number of years. Then you will see more limitations, and then visiting with them every so often would be good. So again, palliative care at any time of the disease, and this is not really mean that you are given up on. So multidisciplinary care of PD. So in the ideal world, we should really have all these people part of the team. So in the first Parkinson's Foundation Allied team meeting, there was all these different specialists. So even a sex therapist, making a lot of sense and attesting how much she has had a chance to improve lives of people through her advice. So all these different specialties have an important role. And so here at the University of Iowa, we are a referral care center, and we work very closely with the VA just across the street. I am here right now, but my office is here actually. So, and we have a rather big team, with different providers, physicians, nurse practitioner, and also our neurosurgeon, our psychiatrist, physical therapist, neuropsychologist. And so it's very important to have a team that can answer to different needs of the patient. Now, exercise. So exercise has various effects. So there are different types of exercise: aerobic, strength, balance, agility, multitasking, stretching. So the most well studied is aerobic, but the others are also important. All of them are important. And boxing, although not very well studied, kind of is a combination of these. It's very popular among patients. What it actually does is it, besides the psychological boost, it also involves all these different aspects, but it needs more study. So the rule is really do whatever you will stick to and enjoy. So we did a aerobic exercise study here in Iowa about 8-9 years ago. For 3 years. We had patients exercise brisk walk for 2.5 hours per week. And these were rather independent patients. And we showed there was no control group, though. We showed that patients could do their walks, in the community and improve their aerobic fitness, which led to improvements in their movement abilities, executive functions, quality of life. And that study really got attention. It was, even though it was a small study, it was carried in the media worldwide. And I was very entertained to see how my name was spelled in Chinese after I Googling myself a few times during those days. So one of the there was a presidential panel on exercise, and which also affected the American Heart Association recommendations on exercise. So the minimum recommended is a moderate aerobic exercise for 2.5 hours a week. Let's say 30 minutes times 5, or 3 times 50 minutes. So we are currently doing such a study in Iowa. We are having patients exercise 50 minutes. We build it up over 6-8 weeks, 3 times a week, compared to a health education class online. And we are looking if their aerobic fitness, brain structure, driving, and various Parkinson measures are improving as a result. So this study is still ongoing, has more than a year to go. So it's very important to get involved in research, because if we don't participate in research, then how are we going to find answers if various drugs or behavioral interventions like exercise work? So what are the ongoing areas of exercise, research? So of course, there is research ongoing on symptom treatment of Parkinson's, but lots of resources are also dedicated to the study of underlying pathways why people end up having Parkinson's. Unfortunately, none of these different agents are ready for clinical use. So I have been observing this field, for 25 to 30 years since my earlier education, but there is really steady progress. We didn't even know a gene until 1997. We now 7-8 genes and lots more information. So I'm very optimistic that better days will come. We also are doing a major study on understanding the brain pathways in Parkinson's disease, and hope to become an NIH Center of Research Excellence. We have already several major grants from NIH and the VA and DoD. So in summary, Parkinson's disease symptoms can be treated effectively, I should say, in most patients up to a certain stage. Symptoms vary from person to person and can include movement and non-movement, meaning motor and non-motor symptoms. A personalized treatment approach with a comprehensive team of providers can help individuals have the best long-term outcomes, as I mentioned. It's really very important to have a team, and you also need to be part of the team as an informed patient with informed caregivers. And support network for Parkinson's is very important. And we are really very grateful to Parkinson's Foundation for bringing different researchers, care providers, as well as patients and their caregivers together in these events like this. Thank you very much.
Thank you so much, Dr. Uch. We really appreciate your time today and sharing your wisdom. We have just a few questions from some of our participants. Frankie was asking, can Parkinson's be tested if it runs in the family?
Yes, meaning genetic test. So we have about 7 genes that are more established. And and there might be other genes as well. And Parkinson's Foundation actually has a study going on called PD generation. And we are a part of this study at the University of Iowa. And it's basically free testing for these common mutations, genetic changes in these 7 genes. So also Parkinson's, you don't need necessarily to come to a center like ours. I think Parkinson's Foundation can also do it through phone and email communication and sending kits and so forth. So yeah, PD generation is a great way of getting tested for genetic cause of Parkinson's disease without cost to you. However, it's also very important to have genetic counseling and so forth. So so here in the University of Iowa, we try to combine it with our neurogenetics division, so that people just don't get a result. Another thing is, even one gene is not, so there are these genes, but each gene has different changes. Not all changes are also diagnostic either. And it's like the blind man's description of elephant. Probably there are many other factors and genes we don't know yet. So we can test for a fraction of people. So if you have familial Parkinson's, we test and it's negative. It doesn't mean that we don't, that it's not genetic. It means that we don't have enough knowledge yet.
I think that alludes to the importance of being involved in research, right? Which you
Again,
highly presented on today, is engaging in research. We have a question from Chavez. They're wondering, what are the benefits of taking medication early in a Parkinson's disease diagnosis?
So first, there are no downsides that are, so because like up to 15, 20 years ago, there was a myth, like if you took the levodopa earlier, then your disease would progress faster. But it was positively shown that was not the case, because those findings were like in petri dish, not in live. So in any case, the advantage is it will probably not slow your disease process down, but when the disease is still not that advanced biologically, you can take full advantage of what medication can offer to you. So instead of living a good number of years slow and stiff and not functioning well, you may be faster with less tremor, with brighter spirits, and enjoy life more. So that's the benefit.
Thank you, Dr. Uch. It is just 1 minute till the top of the hour. We have a couple of questions left if your availability permits us to answer some questions.
Sure.
Okay. Tammy asks if slow-paced walking is effective for people living with Parkinson's disease.
So first, so research is ongoing. So in our study here, we are testing brisk walking, which is like fast enough that you are slightly out of breath, but you can talk in our study. But we select our patients after we put them through different cardiac and many tests. So we don't advise that people do this willy-nilly, only after getting guidance from their primary care providers, neurologists, PT, if necessary, cardiologists, can try that. But again, so there is preliminary research that shows its potential benefit, but more research is going on to confirm. Then there is a very important study going on called SPARKS-3 that is real high intensity training, like 80-90% of max heart rate versus like 60-65% of the max heart rate. And that study is ongoing. It's a large $26 million study across almost 400 patients. So it will tell us so it will tell us if it can slow down the disease. But again, really, any movement is good. The key is safety. And research has shown many Parkinson patients are real sedentary. So use common sense, safety first. Talk to your primary care provider, neurologist, PT, if necessary, cardiologist, and other specialists, and do it only if you can do it safely.
Great advice. Thank you. We have two last questions just for the sake of time. So Tammy is asking, is inflammation of the body associated with Parkinson's disease?
So yeah, that's a good question. So inflammation is like one of the pathways that can affect the health of the brain cells. But are these inflammatory changes the primary thing, or are they due to cell degeneration from other causes? It's unclear. But in particular, like an inflammatory systematic condition like lupus or rheumatoid arthritis causing Parkinson's, there is no such proof at this time, if that's the question. But it's true that there are inflammatory changes in the brain, but it is present in almost all neurodegenerative diseases, because for one or other reason, brain cells keep dying. And when they die, it results in some inflammatory changes because there is tissue change.
Interesting. I appreciate you sharing that with us, and great question, Tammy, and to everyone who's offered a question for Dr. Uch this morning, this afternoon.
So if I can say one thing, so there are some like epidemiological studies that show if people had taken these anti-inflammatory medications, like we take ibuprofen and things like that. So if you look in like thousands and thousands of people, they may have perhaps lower occurrence of Parkinson's, but these are not really definitive findings. So these are interesting findings that that can work as a lead for further research. So don't start taking huge dosages of ibuprofen or similar medications. You can damage your kidneys and stomach.
As our final question, Dr. Uch, what actions can our participants take to manage their Parkinson's disease? If they're just embracing their diagnosis, what would be some key points that you would offer to our participants today to take action?
So if information is power, so therefore the more they educate themselves, the more they will discover about the disease and about what they can do against the disease. And no two patient is really alike. So, and the more they can try to participate in their care and maybe some providers don't jive with their personalities or don't have the kind of the give and take relationship, or so they should really advocate for themselves. And remember that Parkinson's doesn't only consist of tremors and movement disorders. There are many aspects to it. And knowing this, they should also, if needed, educate their healthcare providers even on it, and try to connect to peers and participate in research and in organizations like Parkinson's Foundation and similar. I think these are the main actions. It's like a campaign for yourself in a way.
Amazing. Thank you, as always, Dr. Uch, for your involvement in the Parkinson's community and the many, many contributions that you continue to make to improve the care for people with Parkinson's. We really appreciate you.
Well, thank you. So really being part of the Parkinson's Disease Center of Parkinson's Foundation Center of Excellence Network improved our function here, I believe. Thank you very much.
And also a thank you to everyone who was able to join us today live for our presentation, hosting Dr. Uch and his brilliant mind on all the things that he's contributed to Parkinson's disease and how we can continue to embrace and improve our quality of life in navigating this disease. Many thanks to each of you. A follow-up email will be sent with a survey for your feedback on today's program, and you will receive a link to view today's presentation and the recording, along with other resources for our topic today. Wellness Wednesday. Next week, we will be revisiting our palliative care series that Dr. Uch did address a little bit about today. Next week, we can learn more about common emotions that people with Parkinson's and their care partners might experience and when to seek a higher level of support. We will also discuss how to spiritually add meaning to your life and how the role of a chaplain can help support you emotionally and spiritually. You can learn more about our other PD Health at Home programming at parkinson.org/pdhealth. If you had a question today that was not answered, please reach out to our helpline by calling 1-800-4PD-INFO or emailing helpline@parkinson.org. You can use that same contact information to order our many free resources, educational books, and our hospital safety kit. In closing, I thank you all for joining us today and encourage you to embrace in this new navigation of your Parkinson's disease or that may be affecting your loved one. And many thanks again to Dr. Uch for his expertise. We'll see you guys next week for our next PD Health at Home event.